policy sphere. So I can open this up to anyone for questions if you have anything about the presentation.
Go for it.
I guess this is based more off the talks, but we've thrown around the idea of diseases of despair a lot. And I'm just curious as to whether there's any research or current legislation to try and approach this idea or problem that we're having. Or if there is even a way to address this at all.
I will tell you that the phrase that's been coined, and again coined by a couple of economists, it's been called into question. I think it still has a lot of cachet because I think there's a lot to it. I think if we look, as one of the young women mentioned before, why now? Why now rather than 15, 20 years ago? And I think that there's a lot of factors in our environment, our social, cultural environments, our political environment, economic environments that, again, have driven people to find themselves in different situations, not always for the good. So I don't necessarily know, I think the research, understand epidemiological research is observational, not necessarily interventional. And I think, the data that were used to support the idea, the concept of diseases of despair is, again, more of that epidemiological look. To create interventions, well, it's interesting. So, for example, there's a program right now in Seattle that's being funded by. He's an economist. He's a behavioral economist out of someplace back east, and I forget the name now, but it's called the Opportunity Project. And I can get Ben the information, and I have the resources, but it's really kind of interesting in that what he is demonstrating is that if you take impoverished families and put them into more nurturing environments where there's more access to resources for children, and you improve the resiliency of those children, and importantly, you improve the environments when they are young. Because unfortunately, if you wait until they're adolescents, it doesn't seem as if the intervention is quite as powerful. But what they're demonstrating is that by providing that kind of nurturing, resilient environment to those kids, they have better outcomes. They have less likelihood of turning to substances of misuse or abuse. They do better in school. And so again, I think that when you look at the challenge that we have in public health is that we look upstream, and essentially what I'm trying to ask people to do is to restructure your environment. That's a big ask.
Yeah.
And I'm not going to see it necessarily in my lifetime, but if I can get people to understand the importance of that and how we are a product of our environment. And I think, in many ways, we have to own up to it. We have to accept the fact that the dysfunction that we now experience is a product of our background and our history.
So you mean restructure environment as a treatment aspect to addiction? Okay.
Yeah, again, well, John, I don't want to go for it.
Well, I'm not a huge fan of the term diseases of despair as much, but I think it captures something. I think it's simpler that the best thing that people need, and I don't have a lot of good data on this, it's just, I've interacted with thousands of people that have been struggling with addiction, and there seems to be an absence of hope. And so if you could give people hope, that I think is one of the things that has to go along with it. So being hopeful isn't going to cure addiction in and of itself. You've got to put a lot of supports. Physical. If you're sick, you've got no teeth, you're a meth user, it's going to be hard to get a job. And you can give people hope and build these other pieces in along with it. To me, that can go a long ways. And it's not just poverty. You can be fantastically wealthy and think that the only reason anybody loves you or likes you is because they want your money. You can't trust anybody. You could lose hope. You could have despair. You could be lonely there. But from the outside, it looks like you've got everything. You're a multi-millionaire, but maybe not. And you could, go to drugs for an escape for that. I think that's all I would add to what Bob said. So.
Thank you. Perfect. So thank you both for a great talk. But on the point Dr. Lutz said at the very beginning of your, you both kind of touched it, but your point stuck with me that as a physician, you had previously viewed addiction as something that was, self-implicated and self-caused. And so when we talk about restructuring the environment and making sure that, it's not quite there, like one of the points, I can't remember whose talk it was, but the alcohol curve of those who seek treatment for alcohol addiction, because the social stigma is gone and presumably physicians address it differently. Do both of you see the same thing happening, say, for cocaine addiction, meth addiction? I mean, what are physicians doing? What is kind of the view of thought right now when you go to medical conferences? Is it still kind of the archaic thought of this is something that is self-inflicted, or is it more so moving towards this is a neurological disorder?
Well, I'm going to ask John to speak about the great work that's being done at the medical school, because again, I think that we're seeing a whole new class of young doctors to be, nurse practitioners to be, healthcare providers to be, that understand the science. And then I'll talk retrospectively.
I think it's changing quite a lot. In the College of Medicine, they also explain College of Medicine. In our third year, all of the students have to do what they call a scholarly project, meaning those are research projects that are equivalent to like a master's thesis. And a lot of those are on addiction and pain, addiction, mental health, addiction and pregnancy, things of that nature. So I think there's more appreciation for it and what it stands up. I'm sure Bob and his colleagues are very compassionate folks. I know he is, and I don't think it's ever been a lack of compassion. Maybe so much as a lack of ability to do anything about it. That's driven some of those treatments. If you have a general practice, you've got 4 kids with asthma, a woman who's 70 with knee pain, and somebody with the flu in your waiting room, and then somebody with chronic pain who's in opioid withdrawal comes in, it's kind of hard to figure out how that fits your practice too. So that would be another thing I would say. I guess the last thing I'll say on that is that it seems to me that with the decade of pain and the strong desire to remove pain, at least in first world, that's driven maybe unrealistic expectations for patients from their physicians. And most physicians I know are pretty nice people. They want to alleviate pain. They want to give you what you want for your patient. And so I think there's a change in the public attitude about that that's happening too. I once met with a guy who had just come from the Darfur region of Sudan, and he told me there had not been a single prescription opiate prescribed in the entire year, maybe in the whole country, at least in the Darfur region, where there was really onerous stuff happening. And we prescribed 2 tons or something in the U.S. during that same time. So there's these different societal ideas of the right level of pain.
So from my understanding, just to go off of that, pain and the concept of pain is kind of like that 5th vital sign really emerged in the late 80s and 90s, with the specific guy's name. But is there kind of a changing scope of medical education now for how, future physicians are taught to think about pain levels? As maybe they aren't as indicative as they once were thought to be? Or is pain still a high priority for, stabilizing a patient?
Well, there's different levels. My dad fell and broke his hip. It's called acetabular fracture. So the bone pushed through his pelvis, and it may have been compound too. So he's 80 in the hot ER, bleeding, bone sticking out. His pelvis is gone. And my mom's on the phone talking to me in tears because she and my dad are super worried they're going to turn him into an heroin addict by giving him morphine. And I said, well, I think you should take a triple dose personally and not worry about that. But I think it's that kind of changing thing. It's not so much that the physicians don't want to alleviate as much pain as they can. I think they don't want to create more pain downstream by alleviating acute pain, and they want to work with their patients to have a realistic expectation of where their pain should be. But Bob is the real deal. We should let him chat about that.
Hardly the real deal, John, but thank you. But I think, again, I think it's complex. I would certainly say that people of my generation, physicians of my generation, and I graduated in the 80s, we weren't taught anything about addiction. So I went to school, inner city Philadelphia. I saw plenty of addicts, I saw plenty of alcoholics, I saw plenty of street people, didn't think very highly of them. My 20+ year career in urgent care, the bane of my existence was to have somebody coming in looking for pain medication. And what do? Okay, well, automatically you don't trust them, because obviously they have an ulterior motive for why they're coming in for pain. Even if they were in pain, you still felt that they're looking for something. They were drug seekers. We used to mark down the chart. Back in the old days of the paper charts, we would mark down asterisks, drug seeking behavior, how to handle them. I was practiced urgent care 5 years ago. Still the same approach. We didn't think of people who were in pain or seeking pain medication any differently. Certainly in public health, I have learned a lot in the last 3 years. That's why I joke about hardly being an expert. I mean, I've been dumped. I've been, in this dump tank of this is the environment in which I practice right now. I think the science has been there. I think the newer, younger providers are learning the science from the get-go. And so they're not coming in with a bias. I think the challenge right now, even just in a conversation I had yesterday with someone, is that there's still a lot of old timers out there who still have that bias. That's still stigmatization. And so they're drug seekers. And how do you address it? Well, you don't address it. You don't give them the drugs that they're looking for. And unfortunately, we know that statistically, a very small percentage of individuals who have substance use disorder are actually in treatment. And so there's a huge gap. There's a huge gap that exists right now between people who need treatment and people who are having treatment made available to them. It's just as I said, it's onerous at some level to be a provider and be able to treat somebody, because as John was alluding to, it's not just, oh, you've got opioid use disorder, here's a pill, bye. Oftentimes, there's all the psychosocial infrastructure and dysfunction that accompanies that diagnosis that I can't address in 15 minutes. And so that's why I need a team. I need a comprehensive team of experts who know that, oh, this person is living unhoused. Okay, how can they get a housing back? How can they find a roof? It's Maslow's hierarchy. How can they get a roof over their head tonight? How can they find a meal? Okay, I need to be able to address all those issues if I'm going to be able to address substance use. And that's why, as I said, unfortunately right now across the nation, we're seeing homelessness, we're seeing substance use politicized and criminalized. And I think that's a disservice to the individual, because they don't choose to be there many times.
Agreed. Has it ever occurred to you that housing might be the problem? I know that's kind of a out there question, but I slept outside for 2 years in my 20s, and what I observed is people were kind of unexpectedly found some kind of like tribal aspects of it. Hundreds of millions of years evolving through groups like humans, we're hardwired to that. And what I came up with, what I thought that occurred to me, was that private property, it is kind of like the most prehistoric and profound, pervasive addiction, and it's everywhere. And you got this tribal instinct struggling to manifest. Well, whether you agree with that or not, it allows for us to kind of restate a lot of our issues, not just opioids, but many of them. What we're looking at is more like an effect of depreciating levels of shared spaces. Well, anyway, I found this rat park experiment back in the 1970s where, I don't know, maybe you heard of it, it's pretty famous. They put opioids in clean water, and the rat, when isolated, he got hooked on the opioid. But you put him in a community care with all these people and activities, he stopped doing it. So where I'm going with this is, as somebody with a dad who lives in Spokane for 30 years and is a walking, talking expert on every drug you shouldn't know about, talked a lot about giving people incentives, but it always seems like we're giving the individual incentives, never the community. But what if it can be said that the community is all they care about? Like in my experience, they don't give 2 cents about what you or I want, but that doesn't mean they don't care about each other.
I think that's a great point, and it's kind of what I was trying to allude to towards the end of my comments about prevention. If we can get people to stop using this with these sort of contrived incentives, think of what we could do if we could arrange, I didn't use the word community, I should have, if we could arrange communities or environments so that the incentives are already there. The positive reinforcement is there and readily accessible. I think it could help prevent the allure, if you will, of drugs and abuse.
So that kind of goes into what I really was hoping to ask you about, what other people want to ask you about, but policy-wise, either at a practice level to a state level or a national level, do you see things that are happening or that you would like to see happening to start focusing on the prevention? I mean, obviously, public health problems are multifaceted. We got to have the treatment side, we got to have the prevention side, we got to have multiple interdisciplinary angles.
I do.
But
We
yeah,
just
you have to
received
speak on
this.
some of those.
We just received a grant from SAMHSA, Substance Abuse Mental Services Administration, another one from HRSA, Research Services Administration, that are really designed to focus on prevention. And in the SAMHSA one, we're partnering with agriculture and using extension sites and trying to really push cutting edge prevention efforts out into rural, all communities. We have extension in every county in the state, of course, but really kind of hitting these rural factors. Bob talked about the social determinants of health. There's a fair amount of work geared towards that. But there's other things like infrastructure. I've kind of got this idea about the parallel to the social determinants of health, the infrastructures of health, as things like broadband, roads, clean water, things like that. You have to have that infrastructure in place to be able to take part in a lot of other health activities, and without those, I'm not sure the other stuff can really have its greatest effect.
Maybe just a colleague, a mutual colleague of ours, who's a geospatial epidemiologist, he worked in our opioid treatment program with individuals. And, you know, as John said earlier, OTPs go back to the 70s when methadone was first identified as a medication that could be used to treat opioid use disorder. And OTPs are the epitome of, you're a bad person and you need to have an incredibly structured life, and we will create the structure for you, and if you don't comply with this structure, then you may get bounced out of OTP. And so you have to, I mean, imagine, if you will, that your life is centered about getting up in the morning and somehow getting to the opioid treatment program for you to be dosed with methadone. And until you prove yourself over the first 90 days, you have to be there Monday through Saturday. And we will give you a day off. We will give you a dose to take home on Sunday, but you're there. I've got a life. Oh, I've got to get my kids ready for school, or I've got a job. Oh, wait a second, I have to go to OTP to get dosed. Well, not surprisingly, what this colleague of ours found was that if the individual lived more than a couple miles away from OTP, that infrastructure, they did not have a way to get there. They had to rely on a bus that made multiple stops to get there, and then they had to go find it. They dropped off. And so access. I mean, something as simple, something that we take for granted. I drove down here, okay? I drove an hour and a half to come down and talk to you folks for 20 minutes, and then this. Imagine
you got the pizza.
So imagine that I don't have a car. I'm relying on public transportation. Oh, wait a second, I've got to look at the schedule. Wait a second, I've got to get to work. I've got to go to OTP. I've got to get my medication. I've got to get my kids ready. Good luck. And so again, something as simple as infrastructure that John's talking about, access. It's amazing how many people will tell you when you talk with them that if they had access to transportation. I mean, look at what Seattle's done. Seattle's provided free vouchers to homeless individuals so that they can get to places.
So how do we, sorry, we need to,
Yeah.
How do we get the medical community to start, I know they started, but to start talking about that with patients instead of just treatment? Start asking, how do we get you to the treatment, as opposed to, here is just the treatment?
Well, I think, first of all, it's, as John alluded to, imagine, if you will, that my day is made up of having to see 30 patients, and oh, by the way, I also have to determine whether or not you have this, and that. So then it's really, I mean, we talk about whole person care, we talk about providing a network around that individual of all these services. So we need, again, as a physician, I can't do it, but I have to be sensitive to it. Because if I'm not aware of it, if I'm not aware of the fact that this is a contributor, people don't choose. I mean, again, the language of medicine. So we were talking about people who would be non-compliant with a prescription. For me, that I just bristle at that term. They're not compliant. They can't follow through with it because they don't have access. I tell somebody to go out and exercise, but you know what? They don't have safe access. I tell people to eat right, but they don't have access to. I can, again, for me, the medical students, they get it. They get it. And now we need to have systems that really support that kind of, okay, the ask, but then also being able to provide those wraparound services to provide them.
So when you say you have a team, is that kind of what you're alluding to? Is building these teams over? I don't know if we use that idea of
Yeah, I mean, it's a nurse care manager, it's a social worker, there's lots of different terms, lots of different skill sets that can be brought to bear to really assist people to achieve.
Are there policies that could start helping with this, or that have started, or is that just per hospital, per network, per insurance? How does that begin?
No, that's a great question, and maybe save it for Thursday.
Sure.
Because I honestly don't know. Yeah. I honestly don't know about that.
There are policies and there's legislation to support those things, and there's some policies. So since, as I understand it, your goal is to figure out how to influence policy, it usually doesn't happen that you go into a policymaker and say X, and then there's a policy the next day. I've been fortunate, I routinely meet with our federal and state delegations. I have been appointed to councils on substance abuse by governors in Washington, DC, and it's more just kind of patience and conversations and sharing things. Unfortunately, because so you know what we need to do in your mind. You're probably right, but it's more of a gentle walk, a sprint, I would say.
And stories.
Yeah.
I mean, the story of an individual is incredibly powerful. I mean, John just telling you about his father and his issue. I mean, that's a powerful story. So those stories of one, an N of 10,000 doesn't resonate, but an N of 1 makes a huge difference with an elected official.
That always irritates me. She's got one too.
Okay.
So I've seen her hand go up a bunch, then yours, then yours. Just to be fair.
So, sort of along these same lines of implementing policy, so we obviously can't do it on our own. We need to get more people involved. So how, as a researcher or as a physician, do you have any tips and tricks for best communicating with your average non-scientist about how these issues are interconnected? Why economic inequality, housing access, all of these things are part of this network of drug addiction, and trying to help people to see the larger picture around the issue.
Do you have the health equity circle in Portland?
I don't think so.
We have had that in Spokane. It's a group of students that really get organized and learn how to, the skill sets that go with that. It might be worth checking. I'm not endorsing it, or just you might check that out. We also have the Health Policy Administration program that we've had there. It's transitioning, but you ask a kind of complicated set of questions. Like, I'm not going to ask you how to do microdialysis and substantia nigra and expect a 2-sentence answer. So I also, you said you need more people. Maybe sometimes a group like this, everybody here can say what they want. If you have 50 people, maybe that's too many. So you have to get, when you're trying to influence policy, you have to have the sweet spot in terms of the right people there. Your graduate group, I would strongly encourage you to work with, do you have like a faculty advisor? Is it Clayton?
We do, and we're transitioning. Dr. K. Brothers. Is she an IAD? I think she's SMB.
She's technically CBM.
Yeah, she's in the umbrella program, all confusing. Anyway, our current faculty advisor is retiring.
Well,
So.
I know somebody in Spokane who would love to be involved. Me, so just just saying. But you should easily be able to get an audience with Congresswoman Morris Rogers. Cantwell, Murray. That should not be a challenge at all. They would all love to talk to you. Students in the health sciences often go over to Olympia and advocate for things. And I don't know if you all do that as well. Then there's all these cool fellowships. So I don't know all of you. I think many of you are probably in Society for Neuroscience. So they have like congressional fellows, right? Still, and so does American Psych Association. I would, those could be really cool. Take advantage of those opportunities.
And I guess I would just add a couple of things. As a health officer, what I've done, it's all about relationships. And so the first thing I did when I came on board as a health officer in Spokane is I made the rounds. Hey, I'm Bob Lutz. I'm a urgent care physician by training. I'm now the county health officer. I'm really interested in public health. How is the health department working with you? What do you understand about public health? What are your areas of interest? So find elected officials who, again, really are interested in specific topic areas that you really want to focus on. You have data. Okay, data sell. Data are important. Economic data are important. And again, I think talking about one person, talking about the experience of one individual who you have met, who can demonstrate that issue, is much more profound than the 1,000 and 10,000 people who it's really impacting. I've found elected officials really very open to having conversations. The other thing I've learned is that you go in with an ask. You go in with an ask. So I didn't know that to begin with. So it's like, okay, hey, I'm Bob Lutz. Hey, great to talk with you. And they're, well, what can I do for you? Oh, wow, I didn't think about that. Well, okay, so you go in with an ask. So you go in, you prepare yourself. Hey, I know that this person, for example, Andy Billick, who's our local senator and also the majority leader, very, very interested in early childhood learning. That's his passion. I'm talking about ACEs, okay? There's resonance there. So I've got somebody that I can talk to who's going to be able to push legislation through that is going to support the issues that are important for me.
My question was kind of similar. We've touched a couple times on the stigma surrounding drug use and drug users and how, blame is often assigned specifically to the user, maybe without consideration to environmental factors, and that may be something that's changing, but I'm curious how you approach conversations with your peers who, maybe have those stigmatized views and are resistant to more, empathic treatment strategies or harm reduction as treatment approaches for addiction.
I don't have any peers like that. I win
Good.
I'm still,
I have some family members like that. The most effective way I've seen to do it is to show data, to show efficacy, and then, I said earlier, this keeps kids from burying their parents, and I absolutely believe that's true. At the end of the day, you're going to keep kids from having issues, and that always sells well. I remember once this little boy came up to me and said, well, my dad's an alcoholic, why are they have all these alcohol ads around? They make him sad or something. That's a story I can sell. Good question, first of all, right? It's not very cool. I never had really thought of that, but data, if we do this treatment, if we treat these people, we can turn them into full members of society, if that's what they want, who pay taxes, contribute, maybe are going to cure cancer, who knows? And so that's kind of where I go. Wasted life, it's wasted anguish for kids and family members if we don't treat them.
I think as a physician, I sort of have a unique ability to be able to interact with peers, and we like to think that we're scientists. Again, it's interesting, there's the art and the science of medicine, and I would argue that 75–80% of medicine is the art, not the science. And so I think, when you can provide the science to a physician or to a provider, when they go to conferences, they're hearing this information. I went to the American Society of Addiction Medicine conference last year, 2 years ago now. Wow, look at all this cognitive science. It's been around since the 80s. Why the hell weren't we being taught that? Well, it's a cultural belief, okay? It's a cultural misbelief. And I think that, again, as a physician, I say, are you aware of what the science shows? And understand that when you're dealing with someone who's dealing with addiction, okay, it's a chronic disorder. And yes, you can treat it, and it's no different than treating someone with diabetes using chronic medication. But there's oftentimes a lot of other factors associated with that individual. And so it's not just replacing giving a medication, it's also being able to address all those other environmental factors which may be contributing to why the individual continues. And also, I think, understanding that it's a relapsing disorder. Okay, so again, you can be on medication, but stuff happens. Okay, and there's a trigger, and all of a sudden, like that, I'm back where I was. I mean, I went through it. This is, I had to review a chart. You've heard about the chronic vaping, chronic, pulmonary syndrome. Right now, I actually say it's a sudden pulmonary syndrome. I reviewed a chart this weekend to see if this woman met the criteria. Since August, she's been hospitalized through the emergency room and into intensive care 7 times. She's 24. She has bad asthma, but her drug of choice is heroin and meth, and she inhales it. And so the last time I looked at her chart back, I want to say 2 weeks ago, she was hospitalized, was in respiratory failure, they intubated her, and they actually got her to admit that she wanted to come clean. They actually started her on buprenorphine in the hospital. Right on, perfect. They actually had her hooked up to start inpatient treatment when she got discharged. Right on, perfect. What happened? Her boyfriend happened. They found her boyfriend in bed with her, and she had overdosed. Okay, he was injecting her. Okay, so they revived her. Okay, she's back. Okay, but then they said, your boyfriend can come back in here. And you know what? She checked out AMA. That's a tough story.
Yeah.
Life sucks, and it's amazing when you talk to these individuals. I mean, your heart, again, it just goes out for despair, whatever you want to call it. I mean, life's tough, and when you don't have an out, and all this is what you've grown up with. I mean, your parents. I mean, in our methadone program, we have 3 generations of individuals who are getting methadone treatment. 3 generations, okay, of opioid use addiction. So it's tough. So again, from peer to peer, this is the reality, folks. This is what medicine is all. This is medicine, and this is the science behind it. But here's the art. Thank you.
So I was going to ask. So you're talking a little bit about policy. I mean, we've seen, for example, Portugal. My understanding is they've decriminalized pretty much every sort of illicit substance. So I was just wondering, in general, your opinions on like prohibition versus decriminalization versus legalization for different drugs.
First of all, I like your T-shirt.
Thank you.
Did you ever see Pink Floyd?
I've heard them.
I've heard them. Yeah, I never actually got a chance to see them, but it's like Dark Side of the Moon is a great. Yeah, it's one of my favorite albums.
It very much reminds me of being a graduate student. A warm summer day down by Hawaii Rocks or something. Cooler and Pink Floyd, but that word.
We digress.
Transgressing.
Right, exactly. Digress, regressing.
I think it can work in different. They all have their proponents and opponents. I'm not really in favor of legalization. I don't think that's the right course of action.
And does that include? I'm sorry. Does that include for marijuana, or are you kind of having a gradation among the different?
Some of you heard Rebecca Kraft's talk last week, so she said she was barely in favor of it, and I never quite got over the line because I've never experimented much. I guess I'm a little boring, but I know if my mom and dad were drinking and I was 14 or 15, I thought it was just fine for me to drink and would sneak some booze. And I think that legalizing marijuana maybe can do the same thing to kids. I think we're seeing a little bit of data to support that.
Well, there's also some data that say exactly the opposite. Out of Colorado,
well,
they
Washington
saw
data,
youth
UW
use
suggests-
decline.
Yeah. So I don't think we have the answer yet. It's just my opinion, right? So I would have been more paternalistic about our kids with that one personally, but I would not have kept it criminal. I would have gone for decriminalization. I think that would have been my personal sweet spot on that, and it might be my personal spot on most of these drugs for users. For manufacture and distribution, I do not have the same level of sympathy that I would. So.
Yeah, I think to echo what John said, I think there's a huge difference between someone who's using and someone who's distributing. And and for the book at the ladder, I mean, I have no. When I talk with prosecuting attorneys, I mean, they always talk about max-mins, maximum sentence and minimum sentence, and okay, they want to throw the book at them. And we have an issue in Spokane County, just an aside, I mean, where we have the highest rates of felony across the state. So we have more felony cases in Spokane County than we have in Seattle with 4 times their population. And we throw the book at them because that's the approach of that particular prosecuting attorney. We need criminal justice reform. So if I have individuals who are coming in for a minor offense, okay, they have been caught with drugs, okay, the approach in Spokane is they commit a crime, they go to jail. Well, what about drug court? And what about therapeutic court? And what about getting them into treatment and things of that sort? So I think, again, it's a continuum. It comes back, again, to be able to provide resources to people where they are, what they need in the situation. And I think, there are certain situations where people have committed multiple offenses, okay? I talked with the federal prosecutor, and by the time they get to his level, they're not in his book, and in most of the data, they're not at the place where they can be rehabbed. Conversely, when I look at county courts or municipal courts, and I see an individual who's coming back in, they've come back in, our data show, for example, right now, that I have really high recidivism rates for people who are being booked for minor offenses. Okay, because they don't have any other choice. Okay, they have a fix that they need to take care of, and so they commit a minor crime and they're booked, and they spend on average 28 days in jail, rather than going to therapeutic court, okay, or trying to get into treatment. So it's a continuum.
Are you in neuroscience?
I am actually in power engineering.
Engineering.
Yeah.
You ask all these kind of econ philosophy questions.
Power engineering. What power? Water?
Electric power.
Electric power.
Oh, okay. So along those lines, with some have argued that one of the many things that got the opioid crisis going was the lack of stigma, because it's being prescribed, or it was prescribed, whether it's being shared because you're stealing it from your grandmother's shelf or whatnot. And so along that continuum of illegal versus legal versus criminalization, decriminalization, and recently I'm going to destroy this, the AMA kind of separated themselves from the pharmaceuticals this summer regarding how drug companies start to produce this. We know many of them are under fire for what they've done, what's happening. I'm sure more is going to come out. Where does opioids fit on that continuum? And if we have these policies around pain management, how's that different from marijuana, and why is that different going forward and thinking about how we manage these drugs, and especially from providers? If it's something, medical versus recreational or whatnot. And that's where I always go when I think about this question of delegalization and legalization. How's that different from the opioids, and do we need to rethink how we prescribe those? And I don't know. That's not a position, but thoughts on that, or
don't know, is there a question? I don't know.
Well,
Sorry.
so marijuana is one thing, so my slight inclination to be more in a decriminalization than a legal standing, notwithstanding it is legal, so it doesn't matter, right? So we're kind of running that experiment.
Sure.
And as you allude, there's different sources of data that I'm sure probably are both right. We just have to understand what's mediating those effects. Opioids are legal. You know, they're legal and they're great for acute pain, like my dad, or like maybe pain associated with end of life. And Bob's judgment, mine is that they're a reasonable way to go. So might marijuana be, by the way. It's the diversion piece that it's sketchy. And I'm not sure that decriminalization would do anything for that.
I guess I'm you know, yes, there was a prescription medication, and yes, so there wasn't necessarily a stigma with you having prescription medication because the doctor gave it to you. Right. So doctors know best, right? So it must be okay for you. Oh, by the way, you know, we know right now that, for example, if I give you 5 days of narcotics, the likelihood of you becoming addicted to them is about 13 to 18%. If I give you 30 days, the likelihood is about 1/3 of individuals will abuse those drugs indefinitely. So, the data are out there right now, and again, I think that don't get me wrong, I think that there was a lot of mismarketing and marketing by the pharmaceutical companies, but heck, my classmate of mine in medical school was a pharmacologist. His focus was pain management. Paul taught me how to titrate morphine for people with chronic pain, dying of cancer. Paul taught me this, and I learned early on, morphine's an addictive substance. I knew it. So I think at some level, physicians are trying to find an out by saying, you know what, we didn't know that these medications were addictive. I don't completely buy that. I mean, okay. But I will also tell you, okay, I went to my first National Academy of Family Medicine conference when Tramadol, Ultram, was being released. And I remember vividly going down, you've got all these, back then you have all these different displays and all that, and somebody saying Ultram, okay, it binds to the mu receptor, which is where opioids bind, and it is non-addictive. And so it is a safe alternative for your narcotics. I said, I don't buy it. And now they've shown that it is more addictive than hydrocodone in getting it. So as I said, don't get me wrong, the pharmaceutical industry definitely should be held accountable. They did the same kind of stuff as big tobacco did. I don't discount that. But I also think that we didn't go in eyes closed, so opinion.
I kind of have a question on what you had talked about previously, Dr. Lutz, too, with the issue of race and all of this, and kind of race as an underlying factor for the issues that we're seeing, the decriminalization of marijuana, if I remember correctly from conference data about 1.5 years ago at this point. One of the main reasons that marijuana, legalization was pushed ahead was, well, blacks are disproportionately targeted, and the data hasn't changed on that for, those who are of color being targeted for drug-related offenses still.
Our wars on drugs.
Yeah.
I mean, again, it's crack. Crack was cocaine that only blacks would use.
Do you guys view that as kind of like a systematic, racism thing, though? That's kind of underlying a lot of these things that are emerging.
Yeah. No, I think, and that's where I mentioned a little earlier. I think it's essential for us to own it. I think we cannot deny the institutional and systemic racism, and the othering that has occurred in our country has a lot to do with the issues that we confront right now. I think all the equity issues that are coming to the fore right now, I'm just, we're dealing with a lot of issues around internally within the agency, but just asking ourselves, like redlining. Did you know redlining existed? Do you know what redlining is?
I don't. What is it?
So redlining is essentially, so for example in Spokane, when Spokane was platted for different neighborhoods, okay, those areas were blacks were at higher living areas, those were redlined. And so you as a realtor would not want to sell a home to someone within that red line. Okay, and so right now we also look at the fact that blacks, African Americans in our country have no wealth. I mean, they've got no accumulated wealth because they've never, for decades. I mean, Jim Crow still exists, and so I think coming to grasp of that, and so it's no different with substance usage. You know, again, the war on crime, okay, and the war on drugs, we used blacks with crack as the classic reason for why we needed to address some of these issues. And as I said, I mean, there's lots of articles right now that will talk to the fact that the opioid epidemic became a big picture in our country when it happened to whites, when it happened to whites in the Rust Belt, when it happened to whites across the country. Editorial statement, I have lots of them.
I think that was the best argument in favor of legalization of marijuana.
So on that note though, for your personal opinions, do you believe in calling it marijuana or cannabis in like the medical context?
Yeah. I slap sometimes, I'm sorry.
It's hard to get out of the habit.
No pun intended.
I've got a question for John. So in our conversations before, you mentioned the Washington State Academy of Science, and we've looked into it, and it seems like a really, really great resource for providing information to legislators who are making a lot of these decisions. And so we, as like a graduate student group, a little less qualified in certain settings, but still very knowledgeable, who want to be able to reach out. Do you think that there are better ways for us to communicate what we know on an issue-by-issue basis with legislators, or should it really just come through seeking out things like office visits, like you mentioned before?
No, I think there's definitely ways that, I think, I'm on the board of that, and if you want, I will work with you to help you get connected to that. There may be some cool things we could do with graduate student postdoc fellowships or something. That'd be awesome. And by the way, the Washington State Academy of Sciences last year had a big symposium on the challenges of marijuana research in the state of cannabis. It was called The Highs and Lows of Conducting Cannabis Research.
And then this year it's on opiates, right?
No, this year it was on
Wildfire.
Wildfires.
We don't know next year, but I can get anybody that and it explains some of those data I was talking about. Sorry.
I was just going to say, as graduate students, is it more appropriate for us to talk to these people about our research or coming from a scientific point, or should we use personal anecdotes?
Both. You gotta be flexible. Like Patty Murray, Senator Murray, she loves to talk about like funding. She's a huge champion of making sure the NIH funding is good. So I try to take her into your lab and show her. She seems to love that. And so, Congressman Morris Rogers maybe would be really interested in the impacts on rural communities, and you just kind of got to tailor it. And you have to have multiple things in your repertoire, which I'm sure you all do. You know, we'll get to power engineering.
I put a plug in for the State Board of Health is meeting in Spokane in November, and I sit on the State Board of Health, and so we do a lot of the rulemaking. I mean, not all of it, but when you have different pieces of legislation that have been determined as appropriate for the board to weigh in on, we're the ones who do it. And so, for example, when Senate Bill 1638, which was around personal and philosophical exemptions for MMR, we were the ones who decided on the rulemaking. And so there will be some rulemaking at that meeting in November, which is in Spokane. And so I can turn Ben on to the date and the location and all that.
That would be great.
And it'd be kind of interesting for you to
Open to
sort
the
of see.
public?
Oh yeah, totally. Yeah, it's kind of cool.
Yesterday I was in a dunk tank for half an hour and it felt just like this. I couldn't expect
Do you guys interact with city council much in Spokane?
Yeah, I do a lot. Yeah, it's an interesting time in Spokane, to say the least. You've been following the politics up there?
Yeah, I've been hounding Nadine every chance I get.
The mayor's race is kind of nasty, isn't it?
Well, it's city council and mayor's race, yeah, they're both kind of political. That's why, as I said, it's become a issues around homelessness and around substance use have become sort of the big issue that is going to unfortunately drive this election.
So when are you starting a public health program?
John and I have been in that conversation for as long as I've known John, 15 years now.
We have a large body of public health research. We probably prefer the term community health or community health nowadays, but to get there, I think we better get to medical school for the first.
But again, I mean, again, to the credit of John and the work that they're doing at the medical school, there's a whole population health track in the medical school. So I've had the fortune of talking to one of the classes of students and work with a couple of the second year medical students right now, and they learn about population health. I have one of the students who sort of followed me for a semester, and I got to take them out on home visits, and we're seeing nurse family partnership. Yeah, these are women who have their first child. Their average income is $8,000. They almost all have a history of substance use, homelessness. They have their first child, and it's an incredibly impactful, powerful program to see where you provide those resources to a young mother who wants to do right by their child, can allow that child to have a whole different environment to grow up in. It's kind of cool. That's great. Yeah.
Thanks so much.
Yeah.
All right. Well, yeah. Thank you guys both
Thank
so much
you.
for staying
This was
after.
really great.
And John, we would happily connect about
Yeah.
Academy of Science stuff, please. Yes. Yeah, we are definitely interested in fellowship opportunities, collaborative projects, everything.
Are either of you hungry? I know you didn't get your hands on any pizza.